Okay, now Marsha Linehan is the big name in the field these days. She started out as sort of a cognitive behaviorist, and she came up with this theory. She didn't really have any evidence for it other than clinical evidence, just like everybody else. So she assumed that there was sort of biological vulnerability to emotional dysregulation, which means something called neuroticism is high. It takes less to get you upset, and it takes you longer to come down and get back to normal. So she thought there was a biological vulnerability, and there may or may not be in every case. In some cases that might be more important than other cases if you're particularly sensitive. And the other was invalidating environment. Invalidation is not just disagreeing with somebody. It's basically saying to a child, you're full of crap, you don't know what you're talking about, you say you're angry, you're really not. Who do you think you are? You're never going to amount to anything. It's more than just disagreeing. It's sort of a negation of their personhood. People are even told how they feel. One patient was a minor example, eating an apple, and her father said, why are you eating that? You don't like apples. She never had expressed a preference one way or the other. So what environment is that, do you think? Well, Marsha Linehan doesn't like to spell this out, but it's the family of origin. I don't know where else you would get that kind of thing, but then you grow up and you choose to associate with other people that invalidate you. And you get to the point, I think, where you're actually inviting people to invalidate you by your behavior, and that's what they'll do to you. They'll act like, in certain ways, which will draw that out for you, and they're very good at it. All right, well, she's not the only person that theorizes about this sort of thing. Laura Smith Benjamin is an interpersonal therapist I have a lot of respect for. And again, these are all based on clinical observations, because it's very hard to do a scientific study of this sort of thing, because there's literally an infinite number of variables that you can't control. So unless it's the Truman Show, and you've got them in a cage, you have no idea what's going on most of the time, really. Let alone have control of what's going on most of the time. And she noted 4 characteristics of the families, and I'm talking about the family of origin primarily, the family you grew up in. Family chaos. The borderline individual is subtly blamed for all the family problems or expected to somehow exert control over them. Episodes of traumatic abandonment interspersed with periods of traumatic over-involvement. So you'll be locked in a closet and then raped. It's like... and the over or under involvement pole will predominate, but if you wait long enough, you'll see the other side. So there's one study that really showed there was an oscillation of attachment between hostile over-involvement by the parents and hostile under-involvement by the parents. Efforts by the borderline to establish autonomy are interpreted by the family as indicated loyalty. So these people basically never grow up, and therein lies the myth that they're acting like 2-year-olds. Like the analysts say, although I've had 2-year-olds and they don't really act like borderlines. Although borderlines occasionally do act like 2-year-olds. And then parental love and concern seems to be elicited only by misery, sickness, and debilitation. So you only get attention when you're suffering. If you're doing well, you tend to get ignored or invalidated. Who do you think you are? You think you're so great? We'll see. Okay, now you ask, why are the family asking like that? Well, that's a whole other book, actually. Okay, so there are some, quote, empirical studies, and I'm going to go over 10 of the early ones, because you'll see the same themes, kind of. And they've been replicated countless times. So it's pretty clear. So you see biparental failure, that's where the parents just sort of abdicate the parental role. I remember a story in the newspaper about 30 years ago where these parents just left their small kids at home and went off to take a Mexican vacation. That sort of thing. Neglect and loss, biparental failure. Neglect is a very common theme. Over-involvement shows up a little bit less, but it's there too. Neglect, loss, biparental failure. Overprotection, that's sort of like over-involvement. Again, that shows up a little bit less. The overprotective types are the ones that will answer surveys on patient support group websites. But the abusive parents, of course, are not going to do that necessarily. Neglect, loss, over-involvement, biparental failure, abuse, neglect, loss, abuse. And we're talking about all kinds of abuse. Physical, psychological, sexual, you name it. Not every borderline has been abused physically or sexually. We don't have causes in psychiatry, we have risk factors. No matter what risk factor you look at, biological, psychological, or social, you'll always find some patients that have very little of it, but still develop the disorder, and you'll see other people that have whole bunches of it and don't develop the disorder. So we only have risk factors because these are multi-determined. All right, so how is this going to affect you as a physician? Okay, well, I've listed some of the frequent hazards. Splitting. Whenever you and another doctor or you and the nursing staff are arguing and getting really angry about how the patient is being treated, you have been set up. It's a game of let's you and him fight. So with the nursing staff, they're so pathetic and wonderful and endearing and everything. And when you come in, they're hell on wheels. It's almost like multiple personality. It's not. Please don't mix it up with that, although people that have dissociative identity disorder are often borderline. It's sort of the worst case scenario. Okay, so if you're fighting with the nursing staff or fighting with another doctor, you might have been set up. The counter to that is asking, well, wait a minute. Why are we arguing? What are you basing your observation on? And then you find out that the patient acts very differently, or that they provoke the other person. You know, there are those nurse ratchets out there. You know, so the borderline will find that person and annoy them, and then get abused. Okay, so I generally believe it. We'll talk about how to handle some of this. Drug shenanigans. Now, everybody thinks that the usual, typical drug abuser is always trying to get more meds. Well, sometimes these people exaggerate how much they're abusing drugs. I had a patient that was on, from another doctor, 10 milligrams of Ativan a day, and she would call after hours for refills, early, use multiple pharmacies, when there was a new guy on call. But when they did serum benzo levels, guess what? 0. People believed her behavior and not the blood tests, even though they were done over and over again repetitively, and they all came back. She admitted to me years later that she was stashing them, she was hoarding them. She would insist, well, maybe I'm just not absorbing them. I mean, I am taking them. Suicide threats, those are the big ones, and I'll talk about that a little bit later. Boundary violations, that's when you want to take them home with you. Don't, don't give them money, don't hire them for your office help. Don't have any kind of a dual relationship with them whatsoever. You will regret it. They will find a way to make you do something that is unethical or looks unethical, or they'll accuse you of it, even if you haven't necessarily done it. So these are kind of the hazards for physicians. All right. What about treatments? Well, first of all, let me just mention medication. Medication can help certain symptoms, but they don't treat the disorder. There's no medicine that we have that treats personality. We just don't. Now, occasionally somebody says there's chronic dysthymic people, and you put them on antidepressant, and the personality behavior goes away, but that's really rare. I mean, I have seen that a few times, but most of the time it doesn't. My usual treatment is an SSRI and a benzo, because that combination seems to reduce the reactivity. It's not really an antidepressant. It reduces the neuroticism. It takes more to set them off. And to do the kind of psychotherapy that I do with them, you don't want them having panic disorder in the session. And 40% of females with borderline personality disorder also have panic disorder. Also, panic and rage are physiologically identical. Okay, but there have been long-term studies on 4 different schools of psychotherapy. DBT, which is Marshall and Ann's model, something called schema-focused therapy, transference-focused therapy, mentalization-based treatment. Now, I put it evidence-based in quotes because doing psychotherapy research, especially long-term, and these people don't get better quickly, is very difficult to do because, again, you can't control all the variables. And just like 90% of drug studies, the sponsor's drug comes out ahead of the competition, in psychotherapy outcome research, and 85%, the researcher's home school beats the other one. If you get 2 people that are equally enthusiastic, it always ends up in a tie. It's called the dodo bird verdict. All have won and all must have prizes. But the good news is that these things actually do help. But as a family practitioner, you're not going to be able to do brief counseling or something. You need to refer them out. And it's very difficult to find people that want to take, even among the therapists, it's very difficult to find people that want to take these kinds of patients because they're so notorious for causing a lot of problems. Also, they get better with age. They mellow out. They stop acting out, basically. They're still miserable, they still have terrible relationships if they don't get treated. And they do have a 10% overall long-term suicide rate, so you can't just totally blow off the suicide risk. Okay, now let's talk about things you can do so they can not drive you crazy. Now, it's a little bit of a difficulty because this works on something called a variable intermittent reinforcement schedule. They're going to try and elicit certain reactions, which I'll describe to you in a minute, and they're very good at it. So sooner or later, you're going to do it. But if you only occasionally give them what they seem to be pulling for, that's worse than if you do that all the time, because then they're going to try that much harder. It's like a slot machine. You just never know when the thing's going to pay off, so you keep trying and trying and trying and trying. If you can, and this is hard. It takes therapists a lot of practice to stay cool and do these things. Okay, so what are they trying to make? What are they trying to get you to react with? Well, I found 3 basic reactions, and the first 2 always lead to the third. The first one is they're going to want to make you feel anxiously helpless. Oh my God, the patient's going to commit suicide and I can't stop her. I should run out of the room before I call security. Okay, you are helpless, but that's not the issue. It's being nervous about being helpless. That's the problem. That's what they want you to do. The second one is they want you to feel anxiously guilty. If I just studied more psychiatry when I was a medical student, I probably could help this poor thing. I'm a miserable excuse for a doctor because I've tried every antidepressant in the book and none of them worked. Okay, so that's and the third one is overt hostility. And one patient, the doctor got so mad at her that the doctor said she was a dog and should have consulted a veterinarian. Not good. The great secret, though, is they're going to try like hell to get those 3 responses: anxious, guilt, anxious, helplessness, and hostility. But they really don't want to. They really hope you're going to be different than everybody else. So if they don't get those responses from you, they'll knock it off, and quickly. Nobody believes me when I listen. Obviously, in severe cases, they're going to do it no matter what. But in most cases, they knock it off fairly quickly. People ask me, how can you treat several borderlines? And most people are lucky they have one in their practice, most therapists. Well, I don't know. It's not that hard at all. Of course, they'll still drive everybody else crazy. Okay, it only works with the person that knows this stuff. It doesn't carry over.